Hello and welcome to the webinar on pain mechanisms and management. My name is Michael Smith. I'm a pharmacist at the University of Michigan. I practice on the inpatient and outpatient palliative care service and have an outpatient chronic pain clinic. Today we're going to get into some details on how to manage pain based on the mechanism that the patient is presenting with. The learning objectives for this presentation: by the end of the talk, you should be able to describe the pathophysiology of pain, explore the mechanisms of pain medications, and then associate those mechanisms of pain to appropriate drug selection. So in order to do that, we really have to talk about how pain works first. So let's get into some of the details on pain pathophysiology. Before we do that, we really need to understand pain and how it's defined. So the International Association for the Study of Pain put out a new definition this past year, and I'm going to read it to you and then highlight a couple words that stand out. So their basic definition is an aversive sensory and emotional experience typically caused by or resembling that caused by actual or potential tissue injury. So some of the words that should jump out to you when you're thinking about this is aversive. This is not a pleasant experience. Sensory and emotional. So patients are feeling this both within their physiology, but also within their person. It is caused by or resembling that caused by actual tissue injury or potential tissue injury. And that's a really interesting thing that they've put into this new definition. And it makes a lot of sense as we've learned more and more about pain. One that I'll throw out to you as an example of resembling potential tissue injury is fibromyalgia. We know that patients with fibromyalgia experience pain, but they don't have any injury behind that pain from a physical standpoint. We know that there's something going on within their central nervous system, but there's not actual tissue injury that's causing that. They go on and further define how we should be evaluating pain through this definition. So pain is always a subjective experience that is influenced to varying degrees by biological, psychological, and social factors. And this is one of the things that makes managing pain really, really difficult, is that every patient's pain is different. And you should treat every patient's pain differently. You should treat it to what they need, not what you're used to always prescribing for cancer pain. You should be looking deeper and at the individual in order to better manage their pain, because it is different. Although they may have the same pain generator, their pain experience is different. It's important to understand that pain and nociception are different phenomenon, and that the experience of pain cannot be reduced to the activity and sensory pathways. So nociception is the process of feeling the pain and transmitting that signal within our central nervous system, but pain is the experience. Pain includes not just nociception, but also all of our experiences prior to this injury that are now informing our bodies of what we're feeling. Through their life experiences, individuals learn the concept of pain and its application. This is true throughout life and throughout different pain experiences. Patients may have a pain prior to cancer that feels differently after cancer, because they're learning, their body is learning different ways of managing and handling that pain within their central nervous system. A person's report of an experience's pain should be accepted as such and respected. Because pain is subjective and pain is down to each individual, and it's not just their physiology, but it's their whole life experience, we need to be mindful of that. And that if somebody is reporting pain, that pain may be physical, it may be psychological, but it is still pain to that person and deserves to be treated. Although pain usually serves an adaptive role, it may well have adverse effects on function and social and psychological well-being. So remember, as we've evolved as humans, pain was originally a simple survival benefit for the body to be removed from or to protect the body. Now, pain seems to have progressed past that, and we've developed pains that no longer serve these adaptive roles, but they have significant impacts on the patient's ability to function, their social well-being, for how they can interact with other people, and their mental health as well. And then verbal description is only one of several behaviors to express pain. The inability to communicate does not negate the possibility that a human experiences pain. So just because somebody cannot use words to describe the pain does not mean that they're not experiencing pain. So keep that in mind. You can pick up a lot about a patient's experiences just from looking at their visual cues that they're giving you, or even some biological markers, like are they always tachycardic, or are they tachycardic with touch, things along those lines. But it's important to characterize pain, because as we characterize it, we know that medications work differently for each type of pain. So nociceptive pain is one you're probably most common or most familiar with. This is caused by tissue damage or inflammation. This is cancer pain. It is generally localized to a specific area, and the patient's description of it is fairly consistent in terms of its presence, its location, their ability to touch it, and our ability to treat it. Neuropathic pain comes from a lesion or damage to nerves. This can also be a part of cancer pain. So patients with cancer pain may also have neuropathy associated either with the tumor itself or from treatments. This follows nerve distributions, and so you should be able to pinpoint where it stops, where it starts, which direction it's heading into. This is generally episodic, and patients will describe it as numbness or tingling. The reason it's episodic is as we get lesions on nerves, that then brings about ectopic activity on that nerve, and so that nerve will just start to fire signals randomly. The medications we use to treat neuropathic pain work by decreasing that ectopic activity. And so although we might have patients that would report that an opioid would work for the neuropathic pain, that's actually not working on its mechanism. That's just kind of blunting the downstream effect, whereas things like a gabapentin or pregabalin work by decreasing ectopic activity around that lesion. And then we have nociplastic pain. We also refer to this as central pain or centralized pain. And this comes about from central nervous system dysfunction. Patients are not able to localize this. It is widespread body pain, and it leads to what are called COPCs, chronic overlapping pain conditions. And there are a number of those, things like fibromyalgia, temporomandibular jaw, vulvodynia, interstitial cystitis, irritable bowel syndrome. And they're called chronic overlapping pain conditions because they have generally the same central nervous system dysfunction that are just manifesting in a different part of the body. And what we've come to realize within this type of pain is that there's two mechanisms behind it. There's what's called a top-down mechanism, or also referred to as central hypersensitivity. You can think of this as your fibromyalgia. So there's really no nociceptive input that is causing this. It is emanating from the central nervous system down. It tends to affect females much more significantly than it does males. Younger patients often have central hypersensitivity, and there's a strong family history with those patients. There's also a very strong possibility that these patients have psychological comorbidities, and these patients are at a higher risk of developing other chronic overlapping pain conditions. The other version of this, we refer to it as bottom-up or central sensitivity, and this really comes from patients that have ongoing nociceptive input. Then they develop this centralized pain. And so you can think of this in cancer, somebody that has a chronic cancer pain that then starts to develop generalized pain. They develop things that appear to be like fibromyalgia, that their pain is all over the body. It's no longer located close to that tumor or metastases. It's now their entire body. It's this way because of the central nervous system. This tends to impact females more than males, but not as much as the central hypersensitivity. This is not age dependent. This requires that ongoing nociceptive input that we see in cancer pain. And because of that, there's really no family history within it, but a number of these patients also often have psychological comorbidities. Now, we point this out because patients can have nociceptive pain, neuropathic pain, and or nociplastic pain. So those would be mixed pain states, but medications across these work very, very differently. So as an example, we know that patients that have nociplastic pain do worse on opioids. Their opioid-related outcomes are much worse. They appear to need higher amounts of them if they even work. they impair the body's ability to fix itself. And so when you have somebody that has nociplastic pain, it's important that you're getting centrally acting medications on board. And we'll go through that as we go throughout this presentation, but I want you to be mindful of that and think of a patient that you have that has a central pain or a nociplastic pain, and how you may have treated them or may treat them in the future, depending if they're past or current. So really, how does pain work in our body? So we kind of talked on how we characterize it, but how do we really get down to the nitty-gritty of this so we can start to locate medications that are going to be much better for patients? So first, and importantly, nociception begins in the periphery and ascends through the hindbrain, the midbrain, and the thalamus. And different parts of this pathway have the potential to downregulate these ascending signals. But each of these locations can also become dysregulated. And this then allows for the development of neuropathic pain at that point. But remember that pain was originally a protective mechanism, allowing people to detect and respond to injury, and skin was the first line of defense. This is really where the pain pathway begins, is at the terminal ends of pain-sensitive neurons. The cell bodies of the peripheral nerves are located in the dorsal root ganglia, or the DRG, and these are responsible for conducting the signal towards the central nervous system. Projection neurons then receive these signals and then ascend into the spinothalamic tract, which immediately crosses contralaterally and ascends to the thalamus, more specifically the ventroposterolateral nucleus, and then onto the somatosensory cortex. Visceral pain sensations and autonomic nerve impulses are carried on different tracks, but they have very similar mechanisms. So this is adequate for what we're talking about here. There's a couple other structures that are important within this pain pathway, and so those include the ventral tegmentum, or the VTA here. Projections from the VTA ascend in the mesocortical pathway to the prefrontal cortex, and the mesolimbic pathway to the nucleus accumbens, amygdala, and cingulate cortex. And so what you see with that is that, we're getting into the part of the brain that's the processing center. And this really helps us process pain, mood, emotion, sleep. And so when one of these gets dysregulated, oftentimes many of them get dysregulated. The other part of this that's important is the hypothalamus. It has a role in both pain facilitation and inhibition, with the descending suppression of dorsal horn nociception via GABA receptors in the hypothalamus, acting on descending noradrenergic spinal receptors. And so that's important. So if you start to think about how drugs are working, things like duloxetine, which is a serotonin noradrenergic reuptake inhibitor, that's where that drug is going to work, based on noradrenergic neurons. The thalamus is an important target of ascending spinal activity, its role in pain perception and pain pathology. It can be divided into different areas, the dorsal, ventral, and epithalamus. The dorsal thalamus contains most of the cortical projections, while the ventral thalamus projects directly to the dorsal thalamus via GABA-containing neurons. We're hearing a lot about GABA-containing neurons, so we'll talk about that a little bit later as well. But really what happens through all of this is pain comes up, we process it, pain signals come back down, and we have an ability to stop that. And so let's get into the details of this entire pathway. So what you see here, the different fibers. So the A beta fiber is a low intensity mechanical stimuli needed, such as touch, and we often think that this is required in chronic pain. A delta receptors, there's fewer of these, but these are in deep tissues of the body. And then C receptors make up about 80% of our peripheral nociceptors. It's more easily located. So what ends up happening, regardless of which receptor is caught here, is that the detection of a noxious stimuli occurs at one of these peripheral terminals of the primary afferent neuron. So that's the first neuron that's coming in, and then the fibers will respond differently to different ones. So A beta fibers respond only to non-noxious stimuli. The A delta fibers respond to noxious mechanical stimuli, and kind of low levels of heat stimuli, and then C fibers respond only to noxious mechanical heat and chemical stimuli. These primary afferent neurons have their cell bodies in the DRG, and then they send their terminals into that spinal cord segment, as well as sending less dense collaterals up the spinal cord for a short distance. But really what ends up happening is that the primary afferent neurons synapse onto several different classes of dorsal horn projection neurons, and these go up to different tracts within the higher centers. Most importantly, these are all still considered peripheral nerves. So we have detected our signal, but nociception actually begins once we transduce this. So what ends up happening is the processes that specialized membrane proteins located on these peripheral projections of the neurons detect the stimulus, and then they generate a voltage change at their membranes, and then you need a sufficiently strong signal. If you think back to your biology days of action potentials, that's what's going along here. But what is important here is that this stimulus needs to be strong enough to depolarize the membrane to activate voltage-sensitive sodium channels. So remember sodium channels there, and then trigger an action potential that we propagated along the length of the axon to the central terminals of the neuron in the spinal cord, which you can see in this picture. And then that spinal cord, where neurons terminate, there are then calcium channels. What then ends up happening as pain travels is the central terminals of those peripheral nociceptive neurons. They synapse in the dorsal horn of the spinal cord and then move on to the next cells in the pathway. Dorsal horn neurons are the first neurons of the nociceptive pathway that are located entirely within the CNS. And therefore, they're a key site for modulation of nociceptive neuronal activity when it comes to the central nervous system. And there's a number of neurotransmitters that have been associated or identified within this pathway. And so in here, you can see sodium, you see magnesium, calcium, NMDA receptors, glutamate, substance P, and norepinephrine. So those are a lot of our drug targets that we're talking about here, and those who are trying to modulate the actual nociception pathway here is what a lot of these medications do. Those neurotransmitters in the dorsal horn are synthesized not only by that primary afferent neuron, and remember the first neuron coming in, but by other neurons in the dorsal horn as well, including the descending neurons and various inner neurons. What we know about these neurotransmitter systems in the dorsal horn is these are pretty successfully targeted by known pain-relieving drugs like opioids, like SNRIs and alpha-2 delta ligands acting at those calcium channels like the gabapentinoids. And really, no matter which medication you're choosing there, what their ultimate purpose is trying to stop that action potential from being propagated any further. And so there are several classes of those dorsal horn neurons. Some get input directly from the primary sensory neuron. Some are inner neurons, meaning they would sit in between that synapse there. And then some project up the spinal cord to higher centers. And so there's really two pathways. There's the sensory or discriminatory pathway and the emotional or motivational pathway. In the sensory or discriminatory pathway, the dorsal horn neurons ascend to the spinothalamic tract. Then thalamic neurons project to the primary somatosensory cortex. And this is where we think that this is where pain is able to be specifically located. In the emotional motivational pathway, it's believed that other dorsal horn neurons project to brainstem nuclei and therefore to limbic regions, which is why there's a thought to convey the affective component that nociceptive stimuli evoke. But it's really that when these two signals come together, where these two signals are propagated, is that pain is really created because we've got the location from the one and we've got that emotional or motivational portion of the other. And so that's really interesting. If you think back to the definition that we talked about, is that pain is not just nociception. It includes nociception, but also includes our emotional experience. And then pain stops. And so a couple of slides previously, there was a portion of the central nervous system called the RVM. And it's typically considered a single unit, represents an important relay in the descending modulation of pain perception. So remember, we've been talking about pain coming all the way up to our brain, but we actually can modulate pain via the descending pain pathway. The RVM here lies deep in the medulla near the midline, and there's, we'll call 3 categories of cells. There's on cells, off cells, and then our neutrals. The off cells decrease firing just before nociception, and they're considered inhibitory to pain perception. On cells act oppositely, and they facilitate perception of those noxious stimuli. And those cells express opioid receptors as one of the other ones, or things like cholecystokinin receptors, and that can be blocked by things like lidocaine. The RVM is the main region of origin for those noradrenergic descending pain pathways. So again, this is where drugs like SNRIs are going to work. The inhibition of pain really occurs via this descending pain pathway and via interneurons. Both are shown in that picture there. You can see them. They really, again, their purpose in a normal pain processing is to stop that pain signal, just like medication. So sometimes we have our central nervous system going awry, and we need to use medications in order to get that central nervous system processing appropriately again. So often, and we talked about this for a while when we were talking about nociplastic pain, is that we get changes to our nervous system. Oftentimes those changes are within our peripheral nervous system. And these can be due to things like malignancy or medications or infections or trauma. And when we have those changes, it leads to neuropathic pain, it leads to central sensitization, and it leads to things like hyperalgesia. Neuropathic pain, what happens here is that this comes after nerve injury or dysfunction. And so after nerve damage, what ends up happening is that there's an increased expression and altered trafficking of sodium channels, and that gets increased. And then there's a concomitant attenuation of potassium channels. The altered expression of ion channels results in neurons becoming hyperexcitable and generating ectopic activity. And that's really what is thought to lead to spontaneous and paroxysmal pain, and that's why it's very unpredictable when patients are going to experience that pain. But this is also why, because we have an upregulation of sodium channels, why sodium channel blockers help to relieve that pain. There's also an upregulation of calcium channels at the presynaptic neuron, so that primary afferent right there at the very end of it, that's where there's an upregulation of calcium channels, and that's where gabapentinoids would be used to target. And so another portion here to talk about is the cell body of that primary afferent neuron sits within the dorsal root ganglion, or the DRG, and sympathetic neuronal sprouting occurs, and that actually accounts for sympathetically maintained pain, which is interesting. When we have peripheral nerve injury, causes a multitude of changes in gene transcription and activation of various things, including NMDA, and so that's a place where things like ketamine would be helpful. But nerve injury can also elicit things like hypertrophy and activation of glial cells, including those microglial cells. Remember that following activation, microglia release a bunch of pro-nociceptive cytokines like interleukin-1, tumor necrosis factor, and neurotrophins. And so what this does is that then exacerbates nociceptive transmission and contributes to the sensitization and maintenance of neuropathic pain. We don't really have drugs yet that target that glial pathway, but maybe in some time we will, but that would be another target. Then we have centralized pain, and we talked about what it means from the definitions and what it means from the patient perspective, but let's take a look at what it means from a pathophysiologic perspective. So really what happens is that persistent pain or inflammation causes activation and repetitive firing in those C fibers. And this triggers the release of a bunch of excitatory neurotransmitters like glutamate in the synapse. And this leads to central sensitization. This is accompanied by the release of things like substance P and neurokinins. and that causes persistent depolarization of the cell membrane. And then other things that occur while all of this is going on is things like AMPA and NMDA receptors. They're activated. And again, remember in the previous slide, this then leads to microglial activation, and we get all those pro-nociceptive cytokines as well. So what ends up happening is that we here get lots of upregulation, and this upregulation, when we're talking about central sensitization, is requiring that ongoing peripheral nociceptive input. But similar things are thought to happen for patients that have a central hypersensitivity, like a fibromyalgia. There's some reason that their central nervous system is having that dysregulation. It probably mirrors the things that are occurring here. Pain hyperalgesia is likely a myriad of mechanisms, but we're starting to repeat ourselves when we're talking about the different things that are working. NMDA receptor-mediated neurotoxicity is likely involved here. Decreased neurotransmitter uptake from those primary afferents. And then we think that there's a significant imbalance of pro-nociceptive cytokines in that pain pathway because things have been upregulated and the body is not sure how to handle it. So then how do we handle it with medications? Let's take a look at how those drugs work and how they're really going to fit into this pathway that we've been talking a lot about on. So opioids, there are three main opioid receptors, mu, kappa, and delta. The mu receptors are located primarily in the brainstem and the thalamus. When you have an agonist on a mu receptor, you get things like analgesia, euphoria, but also things like respiratory depression, sedation, and decreased gut motility. When you have an agonist at the kappa receptor, this is located within the limbic system, the brainstem, and the spinal cord. You get many of the similar effects here. The one that I'll add on to it really is dependence and dysphoria. And then the delta receptors are located within the brain, and we don't truly know what all that they do, but we think that they have some effect. And when we talk about opioids, we're really talking about full opioid agonists like morphine, oxycodone, hydromorphone that are agonists across all of these receptors. So where is it that those drugs work? And you can see, as indicated here with the blue stars, it's basically everywhere. So we think of opioid receptors as being very specific drugs because they target opioid receptors, but opioid receptors are present throughout our body. And because of that, they're really sledgehammers for a little nail in terms of how they're working for pain. Those opioid receptors are distributed throughout the central nervous system and within peripheral tissue. Centrally, they're within the periaqueductal gray and the RVM, as we talked about previously. They're all, when you activate those mu opioid receptors in the midbrain, that's where we think that we get opioid-induced analgesia. And so what ends up happening is that mu opioid agonists act by indirectly stimulating that descending inhibitory pathway, which acts upon the periaqueductal gray and other areas, basically activating the descending inhibitory neurons. And so lots of other effects come out of that pathway, but we know that that's generally what really work for pain. When we talk about equal analgesia, there's a bunch of tables like this that are floating out there. They change somewhat frequently, and it's very hard to gather because the data is oftentimes unidirectional, meaning you have patients on one like oral morphine, and then you're only transitioning them to IV morphine, and then we have those two numbers, but we know that they're different going one way versus the other. The patient populations are often very, very different, but in general, these ones come from the NCCN Adult Cancer Pain Guidelines and are generally widely accepted, but it's more often that this is an art rather than it is a science. So you should generally know how to convert those opioids with a table somewhat similar to this. Opioids have a high degree of both phase 1 and phase 2 metabolism, as you can see here. So let's go through a number of these drugs individually. So morphine is relatively poor lipid soluble, has moderate bioavailability for the opioids at about roughly 40%. It penetrates the blood-brain barrier slowly. And then what you see is that it doesn't go through phase 1 metabolism, it goes through phase 2 metabolism to glucuronide metabolites, M6G, which is really responsible for pain relief, and M3G, which is responsible for neurotoxicity and hyperalgesia. Morphine tends to have greater histamine release and hemodynamic effects in some of the other opioids, but because it only relies on phase 2 metabolism, there's few pharmacokinetic drug interactions. Versus when we look at a drug like hydrocodone as an example, this is metabolized by CYP3A4 to norhydrocodone and CYP2D6 to hydromorphone. But the affinity of hydromorphone for mu receptors is at least 100 times greater than hydrocodone. Hydromorphone has better bioavailability than morphine and hydrocodone does. But again, hydromorphone itself is only shown in the middle because it has phase 2 metabolism to 6 and 3 glucuronides, although it doesn't appear that the rate of neurotoxicity is as great with that drug as it is with morphine. Oxycodone is somewhat different. It has phase 1 and 2 metabolism. It has pretty good bioavailability and north of 50%, metabolized though by 2D6 and 3A4. There are a number of abuse deterrent formulations, but none of them have really panned out. But what you really see within our phase 1 metabolism for a lot of these drugs is 2D6 and 3A4. And so as pharmacogenetics becomes more popular and we get more data on them, you might see recommendations to not be using some of these drugs. One of those examples is patients that have that are poor or ultra rapid metabolizers of CYP2D6. So if you look at codeine, codeine requires 2D6 to be activated to morphine. Codeine's a prodrug. So if they're poor metabolizers at 2D6, that means they're not going to make a lot of morphine. It's not going to work for pain. On the opposite end of that, if they're ultra rapid metabolizers at 2D6, that means they're going to make a lot of morphine, and you're really just looking at side effects. Touching on a couple of the other drugs here, fentanyl is metabolized by 3 or 4 inactive metabolites, but is 500 times more lipid soluble than morphine. The one thing to be mindful of with that drug really is that low body mass index and low albumin have been associated with decreased serum concentrations and increased end of dose failure. You can still use it, but you probably end up using higher doses than you think you're going to. Methadone has a bunch of metabolizing enzymes, so CYP3A4, 2B6, 2D6, 2C8, 9, and 19. We know it is an opioid agonist, an NMDA antagonist, and it has some SNRI activity. It has a super long half-life. It is highly lipophilic with a really good bioavailability, roughly 75 to 80%. And we could have a whole talk on methadone itself, so we'll just leave it at that. But another drug I'll add in here that's actually not on this chart is buprenorphine. It's a high affinity partial agonist of mu opioid receptors. Some people will call it a kappa receptor antagonist or a kappa receptor inverse agonist. Basically, it does not agonize the kappa receptor. It's metabolized by CYP3A4. Its elimination is not affected by renal or hepatic dysfunction, or renal function or hemodialysis, excuse me. So good for those types of patients. Comes in a number of various formulations. Then we can get into the arachidonic acid pathway, and this is where both steroids and NSAIDs would work. And so what you can see in the corner is a little picture of what type of pain really this is going to work for. So what ends up happening is that arachidonic acid is a component of the membrane phospholipids, and that's freed after being acted upon by phospholipases. Phospholipase, this is where steroids work within this pathway, inhibiting that mechanism. But then you get arachidonic acid, and then arachidonic acid is broken down either by lipoxygenases or cyclooxygenases, or COX enzymes. It's that COX enzymes that we're really interested in terms of NSAIDs, because that's where NSAIDs work. what we think is that Tylenol is generally considered a weak inhibitor of prostaglandin synthesis, but it's probably closer to COX-2 inhibitors in terms of its in vivo effects. But what's important to note here is that after COX enzymes break down arachidonic acid to various prostaglandins only work locally. They have very, very short biological half-lives. So they're only going to activate things within their local spectrum. They're not going to travel without throughout the systemic system. And so that means we need to get drug to that target, because those prostaglandins are things that are setting off our somatic pain signals here. And so when you're using NSAIDs as an example, you can use them topically at the site of pain as long as that NSAID is going to penetrate deep enough. So if you look at a drug like diclofenac for patients that have this type of pain or nociceptive pain, it's only really good for small joints because it's not going to penetrate deep enough in there, but you could give them an oral version of that will be passed throughout the body and would reach the site of action. So when you're looking at treating patients with both steroids and NSAIDs, you really don't need to if you're using steroids, because you're blocking that pathway prior to getting it. And so what ends up happening is when you're really only adding side effects because you're not getting enough blockade of the COX enzymes further in terms of pain and inflammation, because that's being stopped when you're stopping phospholipase. So there's really no need to be using both steroids and NSAIDs. You can certainly use steroids and acetaminophen, because acetaminophen also appears to work centrally. So this is not its only mechanism of action, but it is the only mechanism of action of an NSAID. Acetaminophen, I'd really tell you to stop using them if patients are on opioids. There's ample data now that says that patients with advanced cancer, those on strong opioids like oxycodone, that acetaminophen is really probably not going to give them much benefit at that point. It's just an extra drug that they're taking. But I will say that if you are going to use it, you should use a gram of it at least 3 times a day. And you should schedule it. This is a drug that works better when it's scheduled, when patients can build enough of it up in their body. And there's a lot of data on it that is the dose. That has come out in both post-surgical acute pain data across a number of types of surgeries. And that data has come out in chronic pain patients like hip and knee osteoarthritis. They require really 3,900 to 4,000 milligrams of Tylenol a day to see a statistically and clinically significant benefit. So if you're going to use it. But remember, it's a very safe and very well tolerated drug. You don't really have to be concerned with overdose. Chronic overdose is really only seen in patients that are using 5 to 6 grams a day for more than 6 to 8 weeks. And acute overdose, you're looking at like 20 grams of Tylenol. But if you're going to use Tylenol, you're probably better using without a combination product. That way you can monitor how much Tylenol patients are actually using. When we talk about NSAIDs, we can talk about their selectivity in terms of the various COX enzymes, and that'll help you determine which might be safer for your patients. So remember that COX-1 plays an important role in the GI tract, the kidneys, and with platelets. It produces prostaglandins that have beneficial effects on blood flow, and COX-1 also causes platelet aggregation. On the flip side, COX-2 is expressed within the renal vasculature and produces prostaglandins that activate and sensitize nociceptors, but has very minimal antiplatelet effects. So think about it this way. The more selective you are to COX-2, the safer for patients with a GI history of bleeding, because you're not inhibiting COX-1 in the GI tract, and therefore you're avoiding or minimizing those antiplatelet effects. On the flip side, the more selective you are to COX-1, it's likely safer for patients with a cardiovascular history, because you're not inhibiting COX-2, which is associated with reduced prostacyclin production by the vascular endothelium with no inhibition on the prothrombotic platelet thromboxane. The cardiovascular effects appear to be dose-related, but there have been more and more studies published on the various cardiovascular effects of all NSAIDs, regardless of COX selectivity. So that may be one you want to use with caution for patients. Here's a table of their pharmacokinetics, and it's a busy table, but what I'll drive home really is just the difference in their half-lives. That appears to be the main difference here. Some have very, very short half-lives, and that requires multiple daily dosing, versus others have super long half-lives, and that's when we would be using them once or even twice a day. So I'll give you kind of two ones on opposite ends of a spectrum. So they're both right next to each other. Ketorolac has a half-life of a little over 2 hours, and so that's why we use it frequently, versus meloxicam, brand name Mobic, has a longer half-life, and that's why we use that once a day. So to really summarize the current available data on NSAIDs for you, if you're going to pick an NSAID, you gotta use it kind of like with Tylenol. So the doses that have shown to be effective both in acute and chronic pain settings are listed there for you. So ibuprofen 800 3 times a day, naproxen 440 twice a day, or celecoxib, which requires a prescription of 100 to 200 twice per day as a start. From a safety standpoint, naproxen appears to be the safest from that cardiovascular standpoint. The gastrointestinal risk appears to be equivalent across all NSAIDs. It doesn't appear that really any one stands out. And once patients have that risk remains really stable. It's low and stable, but there have been fatal bleeds, obviously. And then celecoxib appears to be the safest from a renal standpoint. So if you have patients with renal dysfunction, that might be your go-to. The gabapentinoids, gabapentin and pregabalin, their mechanisms are calcium channel blockers. The picture on the top right, again, just reminds you where that's at. And so these would be for patients that have neuropathic pain or nociplastic pain. Remember, these are both renally dosed. But one thing that's important is that for patients that fail gabapentin due to a side effect or lack or loss of efficacy, a switch to pregabalin is completely reasonable. This has been shown repeatedly in studies in patients with diabetic peripheral neuropathy that failure to one does not mean failure to the other. So you're likely to benefit from trying that second one for patients. You do need to discontinue these gradually because withdrawal syndromes have been associated with seizures. And be mindful of how you switch. So if you have somebody on high doses of gabapentin, you may want to taper them and then switch them over to pregabalin because of that seizure risk. There is also studies of, or a study of direct switch, meaning stopping one and starting the other. We generally do that on patients that are on lower doses. SNRIs and TCAs, so remember, this is really targeting our descending noradrenergic neurons by hyperpolarizing those neurons and blocking those signals from coming up the ascending pain pathway as much as possible. When we look at these, it's really the noradrenergic activity that's working. And so we want drugs that are going to be much more receptive to the noradrenergic neurons. So duloxetine is preferred because of that, because it's more potent at the noradrenergic receptor than venlafaxine is, as an example. But you can't use it in patients with renal dysfunction or liver disease, so patients who are cirrhotic. Venlafaxine can be used in patients who have to dose reduce for those with renal disease, but it can have pretty significant cardiovascular effects in terms of hypertension and tachycardia. And then mildazoprane is actually the only one that's FDA approved for pain. It's very expensive, but if you have patients that for some reason or another do not want to be on an antidepressant, this is technically not classified as an antidepressant on its label. TCAs, they're great drugs that for patients with comorbid insomnia. Remember, they're also highly anticholinergic, some more so than others. You should always dose these at night because they can be sedating. To differentiate when you're picking one versus the other, it's really dependent upon whether you want to take advantage of that orthostasis or take advantage of that sedation, or you need to avoid a drug that's orthostatic. So nortriptyline and desipramine tend to have more orthostasis versus amitriptyline and imipramine, which tend to be more sedating for patients and have more anticholinergic side effects. The number needed to treat really between any of these drugs is generally the same. You're really picking between side effects and whether or not they have liver or renal disease. Sodium channel blockers. So remember, these are drugs that are going to decrease our action potentials. And so when you have neuropathic pain and you have that ectopic activity because of that lesion, that's what these drugs are going to do as well. There's a number of them: lamotrigine, carbamazepine, oxcarbazepine, topiramate, lidocaine, and mexiletine. They functionally all do the same thing. What you're picking, the difference here would be is you're taking advantage of side effects. Like as an example, if I was going to use topiramate, it might be somebody that needs to lose a little bit of weight, or if somebody is more cachectic, I'd avoid that drug. Mexiletine I would only use in patients who have already had a lidocaine infusion and it was successful for them. And then carbamazepine and oxcarbazepine, remember that those drugs carry significant drug interactions. So check with somebody that knows, or check a drug interaction checker before you use those drugs, because not only do they induce the metabolism of the drugs, but they induce their own metabolism as well. And then a bunch of miscellaneous drugs and things to think about when you're using them. Corticosteroids, the preferred is dexamethasone, given its favorable kinetic and dynamic profile. But maybe make sure that you give that second dose no later than 2 o'clock, because you can cause some insomnia for patients. Buprenorphine, because of its different mechanism of action, actually decreases your risk for respiratory depression, and you don't develop tolerance to it. So it's a drug you should consider for a number of patients that are maybe higher risk for opioid-related events. Methadone can be used for neuropathic and nociceptive pain, or even as adjuncts in neuropathic pain. Ketamine is an NMDA antagonist, and we saw NMDA upregulation in various states previously. You can give it IV or oral. It's a very effective drug, and you can up-titrate it very rapidly. Cannabinoids, we don't have a lot of data on cannabinoids, but the use is somewhat common in patients with cancer. And then skeletal muscle relaxants. This is really a misnomer. They don't actually relax skeletal muscle. They're just generally broad CNS depressants. So you should really try to avoid their use. They've not really shown to have any good effect for patients other than self-treating through that CNS depression. So it's a lot of drugs. So how do we pick? Remember, let's go back to our beginning and how we characterize pain. So we have nociceptive pain, or that pain that generates from the periphery. We have neuropathic pain, and then we have nociplastic or centralized pain. And so different drugs are going to work for different types of pain. And this is a way for you to pick those drugs appropriately. So NSAIDs, remember, are working to decrease the production of prostaglandins. Prostaglandins work locally within the periphery. They're only going to be good for nociceptive pain, as an example, versus SNRIs. So SNRIs are going to really help our central pain because they're working within the central nervous system and their descending pain pathway. They're antidepressants, so they're helping patients with that comorbid psychological disease that we know is common in those patients. And they'll even work on nociceptive or neuropathic pain, because again, that descending pain pathway is kind of our common stop within our central nervous system. So I won't go through all of these for you, but these are just ways to begin to start targeting patients' pain with different drugs, and making sure you're picking and choosing drugs that make the most sense for patients, balancing risk and benefit. And I'll leave you with that. Thank you so much for spending time listening to this talk.